Hello, everyone.
Hello, everyone. I'm Dr. Ali Tabari. This is Brittany Ledette, and we are here presenting the second video of this 3-video series on obstructive sleep apnea. And this second video is on diagnosing obstructive sleep apnea, looking for signs, discussing some of the tests used to diagnose obstructive sleep apnea. And also, dentists, dental hygienists, or RDAs can get 1 dental CE credit by watching this video and then answering 6 questions. And Brittany will tell you how to do that.
So the CE credits that we're giving are free. All you have to do if you're interested in answering the questionnaire, you can just email us, which I'll have our email address linked below in the description box. If you see our video on a social media website like Facebook or Instagram, you can direct message our office page, and then we'll also put the link for Dr. Tabari's direct message.
And also, we'll be discussing diagnosing obstructive sleep apnea, along with discussing some 80s music, as we always do.
Yes.
Yeah, so let's get going. So let's say you're a dentist or you're part of a dental office, you're the staff member or whatever, and you want to screen people that may have obstructive sleep apnea. Well, first thing, you could look at them clinically, and I discussed some of the signs, things to look for that make people susceptible to obstructive sleep apnea in the first video. But some of those, just to refresh, include if they have a big neck, which their neck circumference is greater than 15 or 16 centimeters. If you look inside their nose, they have a deviated septum or turbinate hypertrophies in their nose. If you look inside their mouth, they have a big tongue. It's described as macroglossia. Remember Gene Simmons, think of that picture. Mm-hmm. If you look in the back of their mouth, they have large adenoids, large tonsils. They have a lot of excessive soft tissue, and you really can't see their airway. These are all things that make them susceptible to having obstructive sleep apnea, and also obesity. And we're going to discuss a little tongue-in-cheek song that was in the 80s.
Really? Okay.
Not to offend anyone, but Weird Al Yankovic, who made parodies of a lot of songs, did a parody of the Michael Jackson song Bad, mm-hmm. but he called it Fat.
Mm-hmm. I remember.
Yes, so...
It's actually funny.
But not to offend anyone.
No,
he couldn't get away with that today, but
no.
Back then he did that. And
back then times were different.
Yeah, and it was popular, and one of the lines was, "When I sit around the house, I really sit around the house."
Yeah.
Okay, so things to look forward to in seeing if someone may have obstructive sleep apnea. Also, there's some, if you're a dental office that is looking to screen patients mm-hmm. and get patients that have obstructive sleep apnea, there's some questionnaires. There's some popular questionnaires in the sleep medicine world that you could give as your paperwork to almost every patient, mm-hmm. and then see how they score. They have questions on them, and then you see how they score, and based on their scoring, you could determine if they may be at risk for obstructive sleep apnea. One of these is the one we use. Mm-hmm. There's a couple different types that I'll speak of, but the one we use is called the ESS form, stands for Epworth Sleepiness Scale. Okay, so that is a scale that kind of questions, ask the patient some questions, when we give them their medical information to fill out, or,
It's actually attached to our new patients forms that come in, so that they can fill it out at the same time that they're filling out their medical history, because a lot of times patients don't remember to put down maybe all of their health issues, and then they don't think that you know, being at the dentist kind of goes, it doesn't go in hand with sleep apnea. So
yeah, many patients don't know. So we give them this in their initial packet, and the Epworth Sleepiness Scale asks them kind of just like questions about routine things they may do, and if they feel drowsy doing them, and gives them a score. Like if they don't feel drowsy at all, you score 0. If they feel slightly drowsy, they give a 1 score. If they feel moderate amount of drowsiness, they give 2. And if they have a high chance of drowsiness during some of these activities, they'll give a 3. So some of these include, like if they're watching TV, do they feel drowsy at all? And they score it. If no, if mild, moderate, or severe, they'll give a score. One of these other questions, and there's 10 different types. One of these other questions is interesting. It says, as a passenger in a car for an hour without a break, do you feel like falling asleep?
Yeah.
And the key word here is car. And we're going to discuss the Cars, that were an 80s band, and they had a song that's called Drive, who mentions who's going to drive you home tonight. So that could be a place where the Epworth sleepiness scale could be, thought about and recorded. Now, after they answer these, I think there are about 10 of these questions. Then, based on the score, they get a score. If the score is 10 or above, they might be at risk for obstructive sleep apnea, and that's a way you could screen some of your routine dental patients for that. Okay. Now, another questionnaire. We don't use it, but it's used. It's called the Berlin Questionnaire. Okay, and this is another one that again asks certain questions, and you get a score. And the fact that it's called Berlin Questionnaire, we have to mention it because, as you all know, there was a group in the 80s called Berlin, and they did have a song that's very relative to what we're talking about, and their song is called Take My Breath Away. Okay, Berlin, Terry Nunn, and that was the song at my wedding, by the way.
Oh, it was the song you guys danced to.
Yeah,
your first dance.
Yeah. Okay, so Take My Breath Away by Berlin. Berlin Questionnaire, used to assess if people may have obstructive sleep apnea. Okay, all right. Getting more into the unusual, then there's another screening tool, and it's called, getting more weird, it's called Stop Bang. It's pretty much an acronym for things that may give clues to someone having sleep apnea, and I'm going to go through it. Stop Bang. So the first letter in stop is S, and S is if they have snoring, you ask them. Okay, snoring. Then you have T, and if you ask questions about if they're tired or they feel tired most of the time. Then, as far as stop, you have O. That's a little tricky one because you're not asking them, you're asking if they have a bed partner, and if their bed partner has observed them losing their breath at night, or gasping for air at night, or what have you. And then P in the stop is for pressure. If they're diagnosed with high blood pressure, hypertension, that makes them susceptible. Okay, so that's the stop. Then the bang part of the stop bang. So we have B, and that will be for their basal metabolic index, which is a score to determine if they're obese or not, and if their basal metabolic index is over 35 kilograms per meter squared, they have a risk, because that shows that they're obese. Bang, the second letter is A, and that goes for age. If you're over 50, you have an increased risk. Bang, the third letter is N, and we discussed this, neck circumference. When I measured your neck, if it's greater than 15 or 16 inches, 15 or 16 inches, or greater than 40 centimeters, you may be at risk for having obstructive sleep apnea. And then G, bang, the last letter G, and G is for gender. If you're male, you have a higher risk of having obstructive sleep apnea.
Which we learned that in our previous video as well.
Exactly. So we discussed the overview, and G, male gender, and that's what we're going to talk about our next 80s song, which is by a singer called, a one-hit wonder called Michael Brown, and she had a song called So Many Men, So Little Time.
Okay.
So it was a women's, liberation about how she loved men. So that's our, part of the stop bang and the gender being male if you're a higher risk of having obstructive sleep apnea. It's almost 2 to 2.5 times more chance of having obstructive sleep apnea if you're a man versus a woman.
And why is this?
Well, that's a good question. But I think overall men are more obese.
Okay,
But
like body weight.
body weight, but that's still, it doesn't take. That's a great question, and that you
Did I stump it there?
well, you saw that's a good question. It could be many things. Maybe it's hormonal. Maybe it's, and I don't know. I'm being honest, but it could be many things. Maybe it's hormonal. Maybe it's our weight. Maybe because men complain more.
Oh, maybe.
So I know overall more men snore more than females. Yeah. So that's a good question. And as I said, I'm not a sleep doctor.
Right. Yeah.
I love sleeping though.
Don't we all?
Don't we all? So that the patient, you've done the questionnaires, you saw them clinically. Also, you could ask if they snore. Okay, so. And here's the little tricky thing about snoring. So 95% of people that have obstructive sleep apnea snore. Okay? So, however, overall, if you take all the snorers in the world, only 20% of them suffer from obstructive sleep apnea. Meaning, if you're a snorer, doesn't mean you necessarily have obstructive sleep apnea. But if you do have obstructive sleep apnea, then most likely you do snore. Okay? In the complex way that the medical world screws with your mind, there's something called sensitivity and specificity. So snoring would be highly sensitive for obstructive sleep apnea, but it has low specificity for obstructive sleep apnea. Confusing concept.
Yeah.
At any rate, just know you could be a snorer and not have sleep apnea, obstructive sleep apnea. At any rate, that is something you should ask. Okay. Then there's another clinical assessment that I find fault with this, but it's used in this. It's called the Malin Potty score, the Malin Potty classification. What that is, this is used a lot of times in people by anesthesiologists and anesthetists and people that want to be given sedation. And it's also used to determine if they have sleep apnea. And I'll tell you why I don't like it. But what it is, there's two main types. There's the Malin Potty classifications, which basically you're told to rest your mouth and stick your tongue out as much as possible. And then the clinician looks inside, and depending on what they can see, if they could see your soft palate, your airway, they give it a score.
Oh, okay.
Okay, yeah. So 1 being that they could see a lot of things, your airway and everything, and then 4 being that they can't see anything; they can only see your hard palate. That's the Malin Potty classification. There's also a modified version of that, where you're not sticking your tongue out. You're just opening your mouth, resting your tongue. And that's the modified Malin Potty classification. Same thing though. The clinician looks inside your mouth while you're just resting your tongue inside your mouth. And they see how much, exactly.
Yeah.
I don't like that. And I'll tell you why. And I don't like that because part of sleep apnea, part of the way they make something easy, kind of confusing, is that they say basically when you're awake, even if you suffer from obstructive sleep apnea, when you're awake, your airway muscles have tonicity, meaning they're kind of constricting. Okay, and when they constrict, your airway is dilated. Confusing as heck, but I'll kind of explain to you. Meaning your airway, the muscles are constricting, so they're tightening, and when they tighten, they keep the airway dilated, kind of like this pick. Okay, so we have this area where this is the muscles and it's constricting. So the muscle is constricting, but that makes the airway dilated. So this is the airway and it's dilated. This is the muscle and it's constricting. Okay? It's kind of confusing because they're using constriction and dilation in two close proximity areas. Now, when you're asleep, your airway muscles are dilated, okay? So this is dilated and your airway is a little bit more constricted, okay? Again, a little confusion. Muscles dilated, airway constricted. In people with obstructive sleep apnea, their muscles get dilated to the point where this constriction is too small and it blocks airflow. Okay, maybe they have hyperplastic tissue that's being dilated, or maybe they're retraction of tissues for whatever reason. Okay, so you get this concept of muscles constricting, their airway opening. And that's why I have faults with the Malin Potty classification for sleep apnea. It may be used to see if you could sedate patients and intubate them. But for sleep apnea, I have a problem because if you tell someone to open their mouth and you're looking inside their mouth, their muscles at that moment, they could be constricting their muscles or they could be relaxed with the muscles. So there's a lot of variation on the patient about how, if I open my mouth, I usually do open my mouth, especially at the wrong time. But if I open my mouth right now and show you my airway, I can make my muscles dilate, so I have a small airway, or I can make it constrict, where I have a big airway. Personally, that's why I don't like using that to assess sleep apnea, but it is one of the ways in literature that's discussed. Okay. Moving on. So these are some of the tools. Also, now you get a little farther. You take some, you do some images. You take some X-rays. Now there's two types of X-rays. I don't know if not all dental offices have this, but in a cephalometric X-ray, you could look for things that may signal possibilities of obstructive sleep apnea. So what you do is you take a cephalometric X-ray, and which looks at the side, the sagittal view of the skull and the head and neck. If it's a really good X-ray, you can access the posterior airway space. So you take the level at the C2 spine and you measure that radiolucency, which is the airway space. And normal levels of that space, width-wise, is between 10 to 16 millimeters. Average is about 12.5. Now, if it's less than 10, they may be at a risk of obstruction of airflow when they're sleeping. Okay? Also, in very dedicated offices that do have a CT now, there's things that when you could take a CT of the airway, even in dental offices, and you could measure the area, the cross-sectional area, and see if there's adequate space for the airway, or if there's deficient space, which may lead them prone to having obstructive sleep apnea.
It's interesting.
Yeah, so these are some of the way in a dental office you might be on the lookout. Okay? There's that aspect when the dentist is kind of trying to be active in diagnosing. But some dental offices that go and have relationships with some of their ENTs or sleep medicine doctors, they might get referrals for to make this oral devices that we'll discuss in the third video. Okay, so these patients have already been diagnosed with having obstructive sleep apnea, and most likely they've been tried a round of CPAP, but they don't tolerate it. And we'll discuss CPAP and oral sleep apnea devices in the next video. But these people have already been diagnosed. Now, what happens when we're going to go into a little bit about what's going on when when they go to the doctor for this condition, and what tests are used. Okay, so they could go and some ENTs use a fiber optic endoscope to look inside their airway and see what their airway anatomy looks like. Okay, and there's a particular test. It's called the Mueller maneuver. You're too young for this, but there's Ferris Bueller's Day Off, where the teacher actually said Bueller, but this is Mueller maneuver. Okay, so what they do is they stick the fiber optic endoscope inside their nose, and they tell them, you close the nose and you close the mouth, and they tell them to blow. And of course you can't blow air out because your nose and your mouth are closed. Right. This is also referred to as the Valsalva maneuver. And if they see that the space either in their hypopharynx or behind their tongue closes when they're blowing, then they're at increased risk of having obstructive sleep apnea. And
that's interesting.
What is the Mueller maneuver? Okay, but the gold standard and what almost every patient that will get referred to by a doctor will have is a sleep study, otherwise known as a polysomnograph. Okay, and we're going to discuss that a little bit. So there's a sleep study, and what does a sleep study do? A sleep study, they go to a center, which is a sleep lab, and they get all these wires placed on them. There's at least 22 different wires placed on them. And the sleep study records 12 channels of sleep. Okay? And it has a trained technologist to watch you while you sleep. And if you're able to sleep after all this, then things are recorded. Okay? And so I'm going to describe some of the channels in that polysomnography sleep study. Okay? So one, you have electrocephalogram, which is brainwave activity. Okay? You have also you have the electrooculogram. Okay, this measures the movement of your eye. Okay? The rapid eye movement. And the movement of your eye, rapid eye movement, it happens in REM sleep.
Yeah, I was going to say that.
And usually you're dreaming, and that goes, we're going to introduce another song by the Eurythmics that's called Sweet Dreams. Hopefully you're having sweet dreams in your REM dream. And the electrooculogram measures the movement of your eye.
Okay.
You have a pressure gauge that measures your nasal airflow. You have a gauge that measures your oral airflow called a thermistor. Okay? You have wires that measure your respiratory effort. You have an O2 saturation monitor, which we use all the time. You have leads measuring your body position. You have an EKG measuring your heart rate and some rhythms of your heart. And then you have an electromyogram, which measures muscle activity.
Wow.
So that gets us to our sixth song of the 80s, which is called Muscles by Diana Ross.
Oh, I think I've seen that video.
Yeah, it's another song where she tells us how much she loves men with muscles. People bag on the old days, but there was a lot of female liberation in the 80s, Anyhow, so that's Diana Ross, Muscles. Okay, so through all these wires and tests, then you have a technician there on board. Then a doctor interprets, a sleep doctor interprets all the data, and the two main values they're trying to determine is apnea, which is the cessation of airflow for more than 10 seconds or greater, or hypopnea, which is a decrease in the amplitude of airflow for greater than 10 seconds, or for 10 seconds or greater, with accompanying decrease in O2 saturation of at least 3% or associated arousals during this event. Okay? So apnea and hypopnea. Okay? And this is a sleep study, but The problems with it's expensive. I don't know about insurance coverage.
Insurance sometimes cover it, depending on the plan you have.
Okay, great.
Yes, majority of the time.
That's
cover it.
important. And also it's labor intensive, meaning, you know, you have to go there for the night. There's a whole team. I mean, there's a lot doing.
They do have some at-home sleep studies, but you want to make sure they're accurate.
That's exactly what I want, because we're going to discuss that a little bit. So this is a big burden. I mean, I think it's worth it if you know, sleep apnea is such a, but you know, you have people that don't want to do that, and so what's happened is there's portable home sleep study tests. They're more available, obviously, because they're portable, they're smaller. And these aren't good also for people that have other sleep disorders like restless leg syndrome or sleep terror. These aren't good for that. No one's observing them. I mean, a technician's not observing them. But they're home portable sleep studies, and that gets us to our other song of the 80s.
Which is? By
Motley Crue. Remember that movie, Dirt?
So, yeah.
And they had a ballad, they had a power ballad that was huge. It's called Home Sweet Home. Okay, so that's that.
Yep, I get it.
These devices, though, they might have 3 or more channels. They don't have the 12 channels like the sleep study ones.
They're not as invasive.
Invasive, or as, you know, as complex, or they're not as precise, I guess. But they could have things that measure snoring, O2 saturation, nasal airway airflow, heart rate. The accuracy and reliability vary. And I don't, you know, I'm not a sleep doctor, but I don't like these things because it's reported that 25% of the time there's
while you're sleeping, something pops off and you don't
exactly
know it.
There's technical unsatisfactory studies 25% or about 25% of the time. So something's going wrong, but you know, you're either not detecting or you're not putting something on right.
Or you just rolled over.
You rolled over, so
it fell off.
I mean, you're not being observed.
Right.
You know, if you're at a center, someone's observing you, something dislodges, they go in, they put it back, and you know.
Right. Yeah.
So this is why I'm not a big fan of these. You guys could also. Oh, by the way, you guys could also ask questions or give comments. You can give comments in the comment section. And if you have specific questions addressed to me or to Brittany, you could direct message us, and we'll try our best to answer them. Okay, so all these things done. Now the sleep doctor analyzes all this information, and they give a score, okay, based on the number of apneic or hypopneic events that happen per hour that you're asleep. Now, to have a reliable sleep study, you need to be asleep about 4 hours. So you need 4 hours of measured sleep time. And what they do is they take all the apneas or hypopneic events or apneic events, and they divide that per hour. And if you have between 5 to 15 events per hour, they'll diagnose you with mild obstructive sleep apnea. If you have between 15 to 30 apneic or hypopneic events per hour, you have moderate sleep apnea. Okay? Stay right there. With mild to moderate, generally 50% of people could be treated with oral devices. Okay, so just as an aside. However, if you have over 30 apneic or hypopneic events per hour, then you have severe obstructive sleep apnea. And they will diagnose based on that, and they'll diagnose you as having mild, moderate.
They also refer you out based on that too.
Exactly.
If you qualify for sleep appliance, or
exactly.
if a CPAP machine will better treat you.
Exactly. So this is just a little shorter video about diagnosing and what kind of happens
in the process
of you either screening the patient or the patient coming to you from another sleep doctor. Hope you enjoyed it. quick one. But like I said, you just answer 6 questions I'll send to you and you'll get 1 free dental CE. And then join us on our next and last video, the 3rd video, and that's going to be a little bit more involved. We're going to discuss the treatments, possible treatments, both surgically and non-surgically, for obstructive sleep apnea. All right?
Bye, everyone.
Bye.